Good afternoon, everybody. I'm Charles Shapiro, President of the World Affairs Council. Welcome to day 2 of the Atlanta Summit on global health. Yesterday, we spoke about the specific case of India, about how COVID has increased hunger around the world, has complicated pre-existing hunger problems, and about antimicrobial resistance. You can find the videos of those conversations on our YouTube channel, World Affairs Council of Atlanta YouTube channel. Our focus today is, can vaccines win the race against variants and misinformation? Our partners in the summit are CARE USA, the Carter Center, and CSIS. Our content partner is Dr. Helene Gayle, CEO of the Chicago Community Trust. Presenting sponsors are the UPS Foundation, Avanos, John Snow Inc. Our supporting sponsors are Pain Care Labs, Dr. Amy Baxter, Atlanta Global Studies Center, the Georgia State University School of Public Health, the Georgia State University Center for Urban Language Teaching and Research, Kennesaw State University Wellstar College of Health and Human Services, and the Morehouse School of Medicine Office of Global Equity. We're going to change the schedule around today. We were going to start with Dr. Rochelle Walensky, but she is actually meeting with President Biden right now. And so when she is free with that, she is going to join us. And what we're doing is moving the panel up from 12:30 to right now. So I'm going to introduce the panel, and hopefully some of them will be joining while we're talking. The topic of the panel is, can vaccines win the race against variants and misinformation? We have Heidi Larson, PhD, who's the founding director of the Vaccine Confidence Project, the London School of Hygiene and Tropical Medicine, joining us from London. We hope to soon have John Nkengasong, who's the director of the Africa Centers for Disease Control and Prevention, known as the Africa CDC, joining us from Addis Ababa. And Dr. Carlos Del Rio, who's Distinguished Professor of Medicine at the Emory University School of Medicine and Professor of Global Health and Epidemiology at the Rollins School of Public Health at Emory University, joining us here in Atlanta. And this is going to be moderated by Dr. Helene Gayle, the CEO of the Chicago Community Trust. Dr. Gayle is a CDC alum and the former CEO of CARE USA. So Helene, I'm going to turn this over to you, and we'll see where we go, and see if we can handle this, the switch. And so I appreciate it. And Steve, I'm going to ask you to mute your camera, please, and I'm going to mute mine.
Great. And thanks so much, Charles, and to Steve. People may ask, why is this person from Chicago doing this? But as Charles said, 2 of my longest standing jobs were actually in Atlanta, and I was very involved, including being on the board of the World Affairs Council of Atlanta, and part of the original gang that started this whole Global Health seminar series. So just thrilled to be with you. And I see Carlos has joined us. And I would say, while we're going to have to be a bit agile during this, it's wonderful when you have a panel of people, any of whom could be a keynote by themselves. So we will just kind of roll with it. And as people come in, as we've switched the schedule and people have tried to accommodate it, we will roll with it and take the people who come in as they come in, and we will have a interesting discussion, because each of the people come with such incredible experience that I think we can all learn from. So let me start with you, Heidi. The Vaccine Confidence Project has been conducting global studies to really look at public sentiment around the world around the COVID vaccine. And maybe, just to give people some context, you've been doing this work for a long time, even preceding COVID. Talk a bit about why this particular pandemic and how information is flowed is in some ways very indicative of our time and where information is and how we're using information. what are you finding, and how do you see this? We've talked about this being a pandemic that is filled with misinformation and infodemic. I think we've coined that term. Say a bit about what you've learned in your project, and also how does this differ from past pandemics and misinformation?
Thanks, Helene. Well, I founded the Vaccine Confidence Project 11 years ago, just to put some perspective on how long this issue has been bubbling up. But I think there was less interest in it at the time. And in 2015, we developed a Vaccine Confidence Index, a metric, and that, having 5 years of that measurement behind us has really helped see the landscape. So when someone says, how is this different? Actually, we have something to compare it to, which we didn't have before. It was one of the reasons I set up the Confidence Project, because people said, is it getting worse? And I said, we don't really know because we don't have a baseline. It has, in the context of COVID, it's escalated beyond, the questioning sentiment has escalated considerably. And this is, I think, for a number of reasons. As you say, it's been fueled by the underlying issues, particularly around government control, and the whole bucket of different types of measures that the government is in the effort to contain the virus, have limited people's movement, behavior, all the things you do for a pandemic. But the vaccine confidence issues that we already saw before with even measles vaccines and others was a strong and growing, don't tell us what to do. And then comes COVID. So it just basically kind of the kindling was there, and it created this uproar, as it were. In the meanwhile, in the beginning, it seemed striking, but then people hadn't realized yet the gravity of COVID. And I think we've come to a different place where people started to realize this was bad, and actually confidence in the vaccines, and also the announcement with the first announcement from Pfizer last in November, December, was, wow, this actually, there is, these vaccines look pretty effective. So if there's one thing we've seen, is also the volatility of vaccine confidence, up and down. And it's interesting, the title of the session, Can Vaccines Win the Race Against Variants and Misinformation? It might help us get ahead of the variants, but actually, can correcting the misinformation help us get people take the vaccine so we can get ahead of the variants? It's kind of a mixture there, but I think it's been a real up and down, and a real measure of where people are at in the public around a number of issues.
So, John, welcome. I had said earlier that we had to kind of flip the panel, and so appreciate you joining somewhat different schedule than had been anticipated. You were already introduced, so people know that you head the CDC in Africa. So let me turn to you for a minute and ask a bit about, while we're on this topic of misinformation and disinformation, how do you think that is impacting people in Africa? How bad is misinformation? Is it misinformation within countries, between countries, or against countries, if you will? And how is the whole issue of information, impacting your ability to respond to the pandemic?
Oh, thank you, Helen, and greetings to the colleagues on the panel from Addis Ababa. And Heidi, good to see you. I think it's the second time today we are probably on the same panel and discussing this very similar topic. I think In Africa, it is safe to say that we face two challenges in the rollout of vaccines. One is the vaccination itself, which is the ability to roll out vaccines when they are available. And then, of course, that is coupled to the access to vaccines, timely access to vaccines. And then the second, of course, is behavior towards vaccines, which is essentially characterized by the disinformation and misinformation. So both are playing here. I think there's some countries that are visited and actually help to contribute in easing that fear or that misinformation is DRC. I was in DRC in December, and I actually had to arrive there at the height of where they were actually not even wanting to discuss vaccines, even at the level of highly respected people like Professor J.J. Muyembe, where they actually targeted him. So I took the courage to have a press conference, meet with the communities, and to discuss that. But if you see the surveys that Heidi and Africa CDC conducted, we did, she probably mentioned this before I joined, 15,000 people surveyed across 15 countries in Africa, and DRC was one of those countries that was very indicative of the fact that with vaccines, this was way last year before vaccines were available, and today we know that it's still true, that that country is very entrenched in their discomfort and mistrust with vaccines. But on the high end of it, other countries that that study indicated that they will be more amenable to using vaccines, and that is the Ethiopia and others. I think, that study indicated about 90% rate of acceptability of a potential good vaccine. So I think, and that, again, despite the fluctuation, you see those trends that we observe during those large-scale behavioral surveys to be holding true. Now, the good thing is that there are some very shining examples across the continent. The Rwandans, I was just there 2 weeks ago. Their vaccines arrived, and 1 week later, about 300,000 doses of vaccines quickly evaporated. They used it all, and they are looking for more. The Ghanas, when we shipped some vaccines to Nigeria, and Nigeria said, well, we are not really ready to take the 300,000 doses. We ship them to Ghana. Ghana used them all completely. So then you also have the other countries that are they are challenged by capacity. The South Sudan. South Sudan is not an issue of behavior, but rather an issue of the capacity to roll out vaccine, what I called earlier vaccination. The Malawi situation, I believe, has actually been, I would say, misrepresented. We shipped Malawi those first vaccines from the Africa CDC and the AVAC, and they used up about 85% of their vaccines in about 2 or 3 weeks, because those vaccines had a very short lifespan. And then the communication that went around those vaccines was also not helpful, because the focus was on expiring date of the 13th instead of referring to the extended shelf life of 17th of July that the Serum Institute indicated, and that created a lot of confusion. So I think that you have a mixed basket on the continent where they still need work to be done with vaccine, but we see countries that are really leading that process in terms of using their vaccines quickly, and countries that are challenged because of just capacity and the overall behavior issues.
Heidi, we talked a bit about some of the disinformation that is specific to this and ways in which they are approaching it. And maybe if you want to just start with talking about, how do you deal with the disinformation and misinformation that has accompanied this, and even the ways of thinking about it, because I think that there are distinct groups of people who have lack of confidence.
Yeah, thanks, Helene. I really appreciated her, I don't know if you'd call it an anecdote or a reference to the advice she had been given that when you give an HIV diagnosis, to pause and listen. I think we make a lot of assumptions about what people are thinking, often wrongly, and it shuts them down. And I think it's hugely relevant to vaccines. after you talk about a vaccine that's perhaps needed or recommended, to give a pause and hear what people say. So it was a really poignant comment. And I think on the misinformation and disinformation space, it's the same point in a sense, because take the infertility rumor, which is the oldest piece of misinformation in the book. I mean, they're across a lot of health interventions, not just vaccines, although I recently read a whole review of sterilization and various, from malaria pills to different kinds of health interventions. And vaccines are by far the most frequently big anxiety, and probably because it's more population wide, that anyone who feels it's an existential threat in a sense that, but I remember in the polio, in some of the polio contexts where the rumors were about sterilization and polio, people would just brush off, where people weren't taking vaccines, that it was because of that rumor. But in India, for instance, and we had some similar conversations in Kano State in Nigeria, where we said, well, what else, is bothering, or what are the other issues? In India, it turned out that actually the rumor was their kind of excuse in a sense. I mean, it was an easy thing to just say, I don't believe it because of this. I don't want it because of this rumor. But actually, they didn't want men vaccinating their children. And they definitely didn't want men coming from Delhi or some faraway city that they, didn't see them again. And then when we started to talk about, well, what would make it more comfortable, acceptable, and once we found, change the delivery strategy to local women, which in the context of the polio is a bit easier because it's just oral drops. But I had time and time again situations where if you take it past that initial, oh, it's just a it's a rumor, I am afraid of it, but listen for a little more, because there's often a story behind the story. And the other side of the misinformation piece, which really sometimes really disturbs me, is this disproportionate focus on debunking the piece of misinformation. We absolutely need to get the right facts out there and make it clear that something is not fact. But we need to be there with a better story. We need to be there and not just, you can't take it out and not give somebody something else, And sometimes I feel like we're chipping away the bad bits, but then not there with an evidence-based alternative that's actually relevant to what their concerns are. So I think we need to, work more on, building that resilience and giving a better story.
Mm-hmm. Very, very, very true. And I think that idea of not just taking away, but giving is such an important aspect that I think people don't often think about. And I also think, so often health professionals feel pressured to have the answer. And again, that notion of let me listen and hear where somebody is actually coming from is something that I think we could all use across the board, not just for vaccines, but I think in general, to build confidence with healthcare providers.
John, and I just want to say thank you to John Nkengasong, because he had the foresight to say at the very, very beginning of considering COVID vaccine rollout across Africa, we need to understand what people are thinking. And thank you, John, because I think it was really just the fact that you had that foresight is a really powerful message. And actually it stimulated more than our collaborative 15 country study for others to start to think about it too.
A simple but very important notion. So John, let me turn back to you for a bit. And you ran through some of the heterogeneity on the African continent, but one of the questions that has come up from the very beginning is, people would have expected, given the state of health and economic stability in Africa, that Africa would have been really hard hit. But in fact, that has not borne out. Why is that? Is that true? Some people say it's a lack of data, but I think there's a lot of reasons why, in fact, a lot of the preparedness that Africa has gone through for other diseases helped in this. So could you just say a little bit about, why Africa is where it is, and what are some of the things that people should be thinking about in terms of that heterogeneity?
No, thank you, Helen. I gave a talk earlier today in the Lancet conference, and that question came up, and I said I showed some data and some pictures of what we did as a continent. In January, exactly 20th January, we had no COVID cases on the continent, and we wrote a commentary in Nature Medicine where we said there were 200 cases of COVID in the world at that time, and that mainly in China, and that we had to be prepared as a continent because it will hit Africa. And in February 14, the first cases of COVID were reported in Egypt, February 14. On the 22nd, we reacted to that with almost no data. Again, we said to the leadership of the continent, we are going to be hit like a storm with this. So you all come to Addis Ababa and we agree on a common strategy. Surprisingly, within 1 week, about 40 ministers of health came to Addis Ababa for the first time to discuss a common strategy, because we recognize the vulnerabilities that you just mentioned. For the first time, I mean, we have worked in HIV/AIDS for about 29 years, and I never saw a situation where that reaction happened. So some ministers were traveling in Europe, they cut short their trip to come to Addis Ababa to agree. When we left that meeting, we agreed on some very common, drastic, and courageous measures, which was, if you see this, if this is reported, you do the following measures there. It was very clear. To the extent that, I mean, some people say we overreacted because we caused a lot of damage early on in the economy, but we said that was the only way to blunt the first wave of the arrival. By March, we saw that many countries were beginning to report that, but they went into immediate lockdown. If you look at the trends in South Africa, if they hadn't do what we had discussed with them to do, the trends were almost the same like you see in the UK. It was all in that direction. So I think that was phase one of that. Of course, subsequently, the virus spread very quickly and it's in the continent. But the second thing that we believe has really helped us is the strong political leadership. They never, the head of states will come together every month, about 12 of them, they call them the Bureau under the leadership of President Ramaphosa to discuss a common strategy. They would put Africa CDC at the center and say, tell us where this pandemic is. What is this? What is it we should be doing? So that coordination at the very highest level, political level, was very important. Then the youthfulness of our population very clearly has played a role. I mean, I say this based on our own evidence. Within Africa CDC here, a lot of the young people have been infected, but nobody has actually been hospitalized. They only realize that they are infected when they test to travel, and then they go home, stay there for about 10 days cleared, and then the virus, they come. So that youthfulness of the continent's population, where at least 70% of the population is less than 30 years, has actually been affected there. Now, have we reported the cases? Are we underreporting? Absolutely. We are now seeing from serologic data that we have produced ourselves at Africa CDC and others that the serosurvey, that is measuring the number of people that have actually been exposed or are currently infected, is weighed in some countries like Nigeria is several-fold higher there. But the puzzle is, why have there been so many people infected but relatively a lower number of deaths? For sure, we have not seen the kind of scenario that India, that we've all watched on TV with total shock and disbelief. Early on in the pandemic, people said, well, Africa is not counting the deaths, hospitals are overwhelmed. No, that is not the scenario. That is not what we are seeing here. And we again, unfortunately, and very unfortunately, we happen to see how a country can be overwhelmed with this pandemic in India, that we have not seen that. It doesn't mean we will not see that. It just means this first phase of the battle, we have not seen that kind of a devastation there.
So what are your biggest concerns about where the pandemic might go in Africa as we think about, again, this speed of getting nations vaccinated, variants, and the economic impact? And how are you all thinking about that?
Yeah, we have just recently watched what was going on in India in total disbelief and convened another meeting 1 year after all the ministers to adjust our strategy of across the continent. And this was on the 8th of May. We said to all the ministers there, 55 ministers, look, we have to look at enhanced prevention, and that would take into consideration that we maintain public health measures, because that is the best tools that we have under our control. We continue to advocate for uptake of vaccines. That is a separate story. We look at enhanced monitoring and surveillance so that we know where the hotspots are and we can do something with it. And of course, the variants. When we adopted our continental strategy in January last year, there were no vaccines and there were no variants. Okay, we just didn't know about that. So now we are saying we really have to adjust our strategy and increase our ability to monitor for variants. So we've set up what we call the Africa CDC Pathogen Genomic Institute, which collects countries together, and countries that cannot sequence can move their specimens to centers of excellence that can do the sequencing for them under the facilitation and support of the Africa CDC. We're also saying we have to enhance our treatment. That is, make sure that we have our hospitals are equipped with oxygen, because you can easily be overwhelmed if it so happens like in India. So that is going on. But our greatest concern is timely access to vaccines on the continent. We, as a continent of 1.2 billion people, have vaccinated less than 1.5% of the population. Less than 1.5%. I think that is, there are three things that should characterize a common thinking of vaccines in Africa: is fairness, speed, and scale. I mean, until we have and address those three issues there, I think it will be fair to begin to change our thinking and actually focus on how do we deal with this as an endemic disease on the continent. We set up ourselves to vaccinate at least 60% of our population by 2022. At this speed, we'll probably never reach that target, and we can clearly move towards endemicity of the virus in Africa, which will be at best a disaster for the continent.
So, Carlos, let me turn to you and talk a bit about the local context. And I know your work is beyond local and national as well as global, and want to get some of your thoughts on some of the broader context as well. But just talking about Atlanta and Georgia and what's going on there, and how has it evolved, and where do you feel the biggest challenges are? Both you've got Atlanta, where there's Emory and CDC and Clark Atlanta, and great educational institutions that have health embedded. But then you also have the broader Georgia, which is a very heterogeneous, both politically as well as economically, setting. So could you just talk a bit about, because you're a bit of a microcosm, if you will, in Atlanta and the surrounding Georgia?
So Helene, thank you very much for your question. I think that what you have are several things. For the one side, we have been able to get vaccines out, and we have been able to increase vaccination uptake. And you're beginning to also close the disparities between minorities, primarily African Americans and whites. But what you're beginning to see right now in a state like Georgia are two trends that are concerning. Number one is vaccination rates are not bad in cities, but are really bad in rural areas. I can tell you, for example, there's a county in East Georgia called Bacon County, has a population of 11,000 individuals, is essentially a white population. They have given there less than 200 doses of vaccine. So what you're beginning to see is rural counties, and what you're beginning to see is primarily white, primarily male, but also women, white men and women in rural counties, most of them Republican, who simply are not wanting to get the vaccine and not willing to get the vaccine. And I think we haven't talked enough about that. I think really you're beginning to see significant disparities between the the Republican and Democratic leaning populations in vaccine uptake. And I think one of the big problems with this pandemic, we talked about misinformation, but I also think the politicization of the pandemic has been a major, major challenge. And we have made everything political. We made masks political, and now we made vaccines political. And as making vaccines political, we're in a situation right now in which, it almost feels like I take a vaccine and I must be a liberal and a Democrat. I don't take a vaccine, I must be a Republican. And I really think that we have to get over that. I see that as one of the major challenges that we have, not only now, but going forward in really making public health be an effective tool of population health.
And I know you really have been quite a consistent spokesperson on how we, work through some of these issues. Talk about some of the things that you think make a difference, and ways that you have tried through your own work to try to work to heal some of those divides.
Well, I think you have to listen to everybody. You have to listen to their reasons. I think you have to spend a lot of time, talking about misinformation and clarifying misinformation, as Dr. Walensky said. The misinformation, for example, about a COVID vaccine impacts your fertility. I am hearing, information that somebody just sent me right now saying that small fragments of mRNA are going to people's brains and hearts, and that's why we're having, long-term consequences of COVID as a result of the vaccine. So you have all sorts of different misinformations that I think people are making, are expanding. I think, dealing with social media has been really, really hard, because the reality is, a little misinformation goes a long way. And finally, I think we have to be, consistent voices of understanding what people care about. And, this is a conversation that I've had for quite some time, which is, there was no point in telling people get vaccinated if nothing changes in your life. If we're telling people get vaccinated, but you still need to wear a mask and you still need to do this, well, then what's the point of getting vaccinated? So I'm actually really pleased that CDC moved on and said, look, if you're vaccinated, you don't have to wear a mask. The problem is we don't have, the science is there, but the implementation is not. There's no way to know who's vaccinated and who's not. But the reality is, if you take this to the local level, if you make it, in a business, in a healthcare environment, in a school, and say, well, people are going to have to be vaccinated, then all of a sudden you create yourself a safe environment in your community, and you actually give people an incentive to be vaccinated. You can get back to normal if you're vaccinated. And I tell people vaccines are the entry into a more normal life. And that's what people want the most. What people ask me the most, before all this came out, is when can I take my mask off? What do I need to do? It's easy to say you can take your mask off once you get vaccinated, because then you're going to be able to do that. But as I said, how do we operationalize that? My major concern right now, Helene, is that as cases are coming down in the US, but our vaccination rates are not good across the country. They're good in some places, they're bad in others. We're going to see this, outbreaks of disease continue to happen, and they're going to happen in those communities that are less vaccinated. But also what we're going to see is, if we don't address the global pandemic, we're not going to be out of this problem. And, and I'm not talking, I talk to people here locally, I'm not talking about India, I'm not talking about Africa, I'm talking about Latin America. This is south of our border. There's major pandemics happening right now in Latin America. And in fact, the rate per 100,000 population in Argentina and Uruguay and Costa Rica right now, it's much higher than the rate per 100,000 population in India. And if we don't address the local pandemics happening right here in our continent, we have a problem. So we need to get the US to understand that, addressing the global COVID pandemic is not charity. It's actually in self-interest. And it's, trying to control this pandemic is something that we all need to work together and achieve.
So thanks for going back to some of the global, and I want to ask everybody a couple of questions. One is about belief and faith in institutions. I think part of what we saw when the pandemic first started evolving was a real lack of faith in our institutions, whether it was CDC or WHO or other international important public health institutions. What is it that we need to do to restore that kind of trust in institutions? And where do you see that from your perspective? And then I have a couple other questions I want to ask all of you. So I don't know, Heidi, if you want to start with that.
Can you say it again? I was still digesting what was.
So I was saying how important our trust in institutions are. And, in the beginning of this pandemic, we had lack of trust in organizations like a CDC or the WHO. And, part of building the confidence, lack of trust in the FDA and, was there going to be tampering with the science, et cetera. So I think we're going through a period where we really need to start to think about how are we restoring trust in the critical institutions, whether it's WHO, CDC, FDA, et cetera. Where, from your vantage point, do you feel like we could be doing a better job? And what does it take to restore that kind of trust so that we have these global institutions that people also feel are credible?
Okay, you got me thinking about all the trust dynamics, because we often talk in the Confidence Project about trust in the product, the provider, and the policies and politics, because it's often not about the product. And that's when it gets complicated for immunization programs, that, a lot of these trust issues are beyond the scope of the immunization program, and they've got to deal with the fallout. I think we have to bring in the term trustworthiness, because I see a lot of guidance about building trust and from the perspective of the person that actually should be looking inward, or the institution, that rather than focusing on the public and needing to build their trust, we need to give them a good reason. And I think that's where the trustworthiness comes in, and looking in the mirror and seeing. I think in general, there's a lot of finger pointing in this around these issues. And I think if we all, in different ways, looked in the mirror and said, what could we do better, is really, really important. And I think COVID is a huge opportunity for relational building, trust building, and the way we're going to build trust is by being there, for people in ways that they need you. And we're at a time where a lot of people have a lot of needs, a lot of health issues have been parked because of the overall focus on COVID. And I don't think we should, we really need to throw the net wider, because the relationship with the institution and the providers, it's about everything. It's about maybe their issue is more of a mental health issue. And we found in a recent survey in the UK, for instance, that actually vaccine hesitancy was less of the issues, but boy, do we have some major issues on mental health coming down the pipeline. So how can the health and other institutions and government, and even at a global level, focus on what people feel they need, their felt needs, and they'll remember that, and then they'll also feel like they're not just there so you can count your numbers on the vaccine, that actually, your motives are that you care. Your motive isn't just to report to your supervisor that you vaccinated 120 people today, but that actually you understood what other things these people needed. And I think that's true at a local level, but at a global level.
Carlos.
I think that what this pandemic has shown us is that trust in institutions can be lost very quickly, right? Mm-hmm. And I think that two things that led to that is, number one, there was mocking and quite frankly, dismissive of the institutions by their own leadership, right? When the president says don't trust CDC, when the president says don't trust WHO, that matters. When leadership says those things, that matters. And you then cripple your institutions. The second thing is, I think that a lot of our institutions, and I'm speaking specifically about CDC, were muzzled throughout the pandemic. We never heard them speak. And, you know, you have to be out there. You have to, I mean, what made Tony Fauci be a trustful voice in this pandemic? Because he was there speaking, he was continuously communicating. And I think if we learn something, and if we see what Dr. Walensky is doing right now, is she's communicating, she's out there continuously giving messages. And I think trust comes from timeliness and trustworthy communication. And I think you need to be very clear and say, this is what I know, this is what I don't know, and this is try to explain things to people. And the more frequently you do that, the better it's going to be. So you need to give your message, you need to make it correct, you need to say when you don't know things, and most importantly, you need to give, you need to give people hope, you need to give people a path forward, you need to show people that there's leadership. And I think therefore, at the end of the day, this is all about having the right leadership at the right places, because leadership matters. If you don't have the right leader in the right place at the right time, you're going to be in trouble. So no matter, I mean, just think about what we've done globally or even locally. We had incredible pandemic preparedness plans. Everybody thought we were ready to go until we were not, right? All those exercises and all those pandemic preparedness plans simply were flushed down the toilet. And it was because we didn't have the right leadership at the right time there. So that brings me to the third point that I want to make is I think we need to rethink about our institutions. I think we really need to create, I've been a big advocate to take something like CDC and take it out of the political arena and make it more something like the Federal Reserve. Make it more something that is immune from political manipulations and is able to communicate freely and effectively of what the issues are. And I think if we do that, we may be in a much better position going forward.
Thank you. John.
So I can't really add more to what Heidi and Carlos have said, been extremely well put, but I'll say that one is that the science and the institutions that produce science must be protected from politics. I think that is very important. Let me start with the solution, then I'll work backward. Then in my experience in good public health practice for pandemics, there are 4 P's that matter. One is the pathogen, the people, the policies, and the politics. And all 4 P's must be aligned. If the politics step on the science, on the ability to understand the pathogens and influence bad policies, then the institutions suffer. We saw what the US CDC went through. We saw what WHO went through, Public Health England. But I must say that I'm so fortunate that I'm running an institution that the political leadership believe in. I mean, by convening us in 1 year 15 times to brief the head of states of the continent was a good example of where the politics align very well with policy and enable a young public health organization like Africa CDC to actually lead in the pandemic. I think that also has to be projected there. So bad politics would mean bad public health and bad policies there. I think it's very clear. We have to protect that, protect the science and protect the institutions from the political harm that might actually bear. So I agree with Carlos that looking at these public health agencies and trying to create a shield around them that will enable them to act independently and use science and data to drive the response is very, very critical.
So there's several questions in the chat, and we're not going to be able to get to all of them, and some of them you've kind of answered along the way. But one that we haven't touched on is the role that patents play in facilitating or being an obstacle to the vaccine rollout, particularly in developing countries. Maybe I ask you, John, if you have any thoughts about, could we be doing patents differently? Would there be a way that we could have a different kind of arrangement that would allow for broader manufacturing and therefore, broader scale up and access to vaccines with different patent arrangements?
I mean, I can fully agree with that we need in pandemics and in threats that face humanity, such as the pandemic we are dealing with, a temporal waiver of those patents to enable scale up of vaccine manufacturing or scale up of diagnostics or therapeutics is common sense, I think, and is beneficial to everybody. I think our official position at the African Union is exactly that we should be wavered. The South Africa and I believe India have been championing that cause for a while now. I think we go on the record that we are extremely appreciative of the move the United States government has taken to support the waiver for IP. We look forward to how the discussions will unfold. We know that that doesn't immediately put a vaccine in or diagnostics into the theater of response, but it is a very important step. From where I sit, I think we've argued severally during this pandemic that the health security architecture of the world we live in has to be redesigned so that you regionalize it and decentralize it as much as possible. Look at the crisis we are facing in Africa with respect to the access to COVID-19 vaccines. It was designed such that all vaccines that COVAX, as the WHO mechanism, will supply Africa will come from India. Okay, so that was using just one strategy to supply a continent of 1.2. Then India got caught up in a situation that they couldn't export. The continent remains naked and exposed. Just imagine if Institut Pasteur in Senegal, South Africa, Morocco, Egypt were producing some of the vaccines, we would not be in this situation. So I think it is really something that the world must embrace. I look at temporal waivers. We don't want to kill innovation, but we are saying that it is important that we come to an arrangement that in times of crisis like this, humanity should benefit from it.
So it looks like we're almost at time. So maybe I'll kind of roll in a couple of questions that I see have come in. And they basically are around how do we, at a time when, clearly we believe that the vaccine is critically important for, how we respond to this, but there are also other public health measures. And what's the balance between giving people the sense that vaccine is the strategy versus the more holistic and integrated? And have we gone too far in the direction of a focus on vaccine without thinking about the more holistic? So from your perspectives, just to get your thoughts on that and any remaining points that you want to make before we wrap up in 5 minutes. I'll start with you, Heidi. Well, I'll start with Carlos if you want.
Yes, let me just.
So to me, Helene, I think that you and I come from the world of HIV, and again, I go back to thinking about how we have thought about HIV and the things that we need to do, and I want to go back to this whole issue of poverty and structural racism and marginalized populations, because whether we're talking about the US, we're talking about Europe, we're talking about Africa, this pandemic is not hitting people equally. And those of us that are able to work from home, those of us that are able to be isolated, that can do certain things, that have a home, are less likely to get infected, are less likely to die, are less likely to be sick. So all I want to say is that I think we really need to think about addressing social determinants of health. This is not just about a vaccine. This is really about improving people's lives. This is really about making, the ability to have access to healthcare, the ability to have access to preventive care, the ability to have a livable home, a livable wage, a livable salary needs to be a priority. It is public health that really has to push this. We cannot continue to afford, not addressing the social determinants of health. And I think if there's one lesson out of this pandemic is that let us not forget that the excess mortality we're seeing from this disease is in great part driven by poverty and social determinants of disease.
Yeah, and I think to your point, it will go a long way towards establishing trust and trustworthiness if people feel like their core needs are being met at the same time as we're giving messages around getting vaccinated. Heidi.
Yeah, I mean, my pause is that I was thinking that my previous comment was very relevant in terms of meeting the broader needs, and I was trying to get a new angle on it. But thank you, Carlos. That's yeah, because I mean, I think there's a couple dimensions. One, the actual health situation and the access and the lower access, and this as they framed it, the social determinants of health, but also that it's a cycle because that's also eroded the trust. And it's a knock-on effect, and I mean we've sometimes people talk about, well, these groups don't want the vaccine because of historic issues. Well, there's also it's very alive and real in now, and that's where I think addressing the social determinants of health. I just before COVID hit, together with the Lancet, we launched a commission on the emotional determinants of health, because I was feeling pretty strongly that the social determinants of health framing is very much on historic data. It's on data that was collected, you know, by the time you get the data and the demographic data, it's, you know, a year old and at least. And the kind of and you, in that sense, you see where there are persisting gaps that, you know, over time, but there are also other dynamics that are play into these emotions and the trusts and the sense of stigma or marginalization or whatever it happens to be. Fear. I mean, fear is hope, the power of hope in keeping people in there, especially when they look around and they haven't been given a lot of fuel for hope. And so we're developing a spectrum of emotional determinants, from hope as a motivator to fear as an inhibitor to distrust. So I just to throw in another angle on that, it's really important, particularly with the dynamics, not instead of social determinants, but as an additional feature of the landscape. Thanks.
Yeah, and I think to your point, the emotional aspect in some ways are results from some of the social determinants. And so, you know, that lack of hope that comes from not having your core needs being met, you know, is one of those kind of knock-on effects. So thanks for rounding that out. And John, last word, minute to wrap up.
No, thank you. I think that Heidi and Carlos summarized it well. Let me just end up by a reflection from from a commentary that one of a global health hero of all times, Peter Piot, once wrote in the Lancet. He said, "Health is global," and I think that has always resonated with me, which means our aspirations are the same, our circumstances are different, and we have to learn from this pandemic that the inequities that we have talked about have further been exposed by this pandemic, that we are more connected than we thought we were, and that we are actually more vulnerable, regardless of where you are in the world, than we thought we are. So I think it speaks to the fact that we have to look at health in a more holistic way, and global health has actually become meaningful during this time of pandemic. I think before it was global health perhaps was defined as maybe flying to Africa or Latin America to help address health issues there, but it's truly, I believe, in my view, the first time that global health has actually mattered. So we really hope that a new public health order will emerge from this pandemic.
Well, thank you very much. And you know, as I said when we started, any one of you could have been, you know, a conversation by yourselves. You, all three of you, bring a wealth of experience. I am proud and pleased to have known you for decades and had the pleasure of working with all of you. Thank you so much for this incredible, and thanks so much for your flexibility as we had to kind of rework the panel a bit. So turn it back over to you, Charles.
This has been a terrific panel. I've thought that the whole day has been amazing, and Dr. Walensky's intervention was really a great public service ad that we ought to be showing everywhere. So thank you all. I hope you will all join us tomorrow at noon. Our keynoter tomorrow, kicking off at noon, is going to be Gayle Smith, who is the U.S. Department of State Coordinator for Global COVID Response. We'll run from noon to 1:30 tomorrow, just like we did today. We're going to post the videos from today as quickly as we can this afternoon. It's on our YouTube channel, the World Affairs Council of Atlanta YouTube channel. Helene, Gayle, thank you once again. This has been terrific. Heidi, Larson, John Nkengasong, Carlos Del Rio, thank you. And if Rochelle Walensky's listening somewhere, I hope she's feels adequately. Thanks you, just absolutely extraordinary. Thank you all. I'll see you tomorrow at noon. Bye-bye.